I'd like to thank the organizers for inviting me to deliver this keynote on health. As you'll see in the first slide, I also wish to acknowledge Lisa Peretti, who is my colleague and partner in the work that I'm about to discuss. I always begin my consideration of this work by thinking about this issue of chronic illness. You'll see here on this slide to the left-hand side that the top 10 global causes for death. There are two on this list that are of particular interest to me in the work that I do. Heart disease and diabetes, particularly type 2 diabetes. These are non-communicable diseases. They are often lifelong in terms of their implications. And they require that there are things that I do as an individual, but also that there are ways in which the community can either support me or can make my life more difficult with those diseases. To the bottom right of this slide, you'll see much of my work is done in the United States. And so I look at that 6 in 10 adults in the US have at least one chronic disease, and 4 in 10 have 2 or more. And these are the leading causes of death and disability and the leading drivers of our annual healthcare costs. In the top right corner, I also want to talk about the linkage between physical health and mental health, which is one of the themes for the health section. People with other chronic medical conditions have a higher risk of depression, and people with depression are at higher risk for other medical conditions. And yet, even when other illness is present, depression is treatable, so that there's a complex interaction between physical and mental health that we really need to be concerned about and involved with. But when I think about these chronic conditions, I'm not a physician, but yet I think I have an important role to play in how we manage our chronic conditions. And I think that largely because of the social determinants of health, that we realize that so much of what happens from a health perspective is influenced by all the other things that go on around us in our lives. Our income, the physical environment, our employment situations, our levels of literacy are all important. But also there are things like healthy behaviors, there are things like access to health services. What about the levels of social support that are available to me? And what's the impact of gender in the midst of this? And how are we permitting gender to perhaps influence access, for example, to healthcare? And so I think that these are areas where, as individuals and as communities, there are things that we can do that will improve the management of chronic conditions for everyone. So this next slide has the chronic care model, which is something that really looks at the relationship between formal healthcare, between health systems and the community and the individual. And I draw your attention to that idea that there is an activated community that includes informed, activated patients, and that productive interactions and relationships involve their interaction with practice teams, with community partners, as well as the healthcare system. And that's how we arrive at good outcomes. So in this slide, I'm really interested in trying to understand the linkages, certainly between health determinants over the life course, but also health outcomes and its distribution in the populations that I work with, and then to look at the interaction that policies and other interventions at the individual and the population level can have on whether it's influencing determinants of health or influencing health outcomes. So as I work to develop and test and encourage interventions, I'm also greatly influenced by what we call the REAIM framework. REAIM is reach, effectiveness, adoption, implementation, and maintenance. It really causes us to sit back and think about, well, the evidence says that this intervention will have a great effect, so why doesn't it happen? Well, it doesn't happen perhaps because we're not reaching the right people. It doesn't happen because there aren't organizations who either are able to or who want to adopt it. It doesn't happen because we don't implement it in the right way. And often it doesn't happen because we have no mechanism for maintaining an intervention once we start it with great fanfare. So effectiveness is still important. That's the other component that I haven't addressed just yet. But let's think about sort of what does it mean to say that an intervention is effective? I think an intervention is effective when it becomes widespread in a community. I'm less interested in an intervention that only works for 3 or 4 people. I know it's important for them. There are other people who will do that work. That's not the work that I'm focused on. I'm focused upon interventions that will become widespread. And so with that in mind, I want to give an example from my work on building healthy communities of sort of the kind of work that's done and the kind of issues that we need to be thinking about. So this was the Healthy Hearts on the Hill Coalition. And it was a genuine coalition of a group of neighbors. And as a university, we were one of the neighbors. We were in a community called West Hill. And the community decided that they wanted a project that would mean that their neighbors would have the means and access to live heart-healthy lifestyles within the community and supported by the community. So we started out with some particular strengths, and each community is a little different. What we were fortunate to have was that we had developed some programs already, like the Neighborhood Health Advocate Program, that was serving a very, very small number of people. We had the faith communities in West Hill who were organized and who wanted to make a difference. We had a medical school that was nearby that had a small community service program and was willing to partner with us. We also had capacity for evidence-based health programming, and that had been demonstrated effective in individual behavior change, in which if the community was interested, we could very quickly stand up capacity to deliver those. But I think the most important thing that we had was that there was an interest among the agencies and individuals in the community to build a coalition. And there was an interest in doing this in a partnership way, in a participatory way. So when I think about traditional community change strategies, we tend to choose a unit for intervention. We're either largely focused on individual change or we're largely focused on community change. And yes, there's a lot of communication back and forth, but we're interested in understanding what that means for the individual or what it means for the community. In our coalition, we wanted to do something a little different. We were really interested in a community change strategy that really mobilized the individuals in the community. We worked on partnership building, we worked on co-creation of community-based programming, and we utilized evaluation to understand what the impact was at both the individual and the community level simultaneously. Not one or the other, but both. So we then sort of really targeted in on sort of, well, where do we want the change? What is it that we're doing? What are we targeting? And we certainly looked at the system level, looking at the health providers, the structure of healthcare delivery. But we also looked at the role of faith and community-based organizations in promoting change. And we looked at the roles of individuals, of businesses, of the social networks that already existed in the community in promoting change at all levels. And then we looked at how well we were building community-driven solutions, a strong coalition, where we mobilizing the community, where we advocating and where should we advocate for systems change at the level of policy, regulation, and practice. It was a grassroots effort, certainly in support of individual behavior change, but something that was permeating the whole community. We looked at offering screening programs to build greater awareness of the chronic conditions. We looked at referral systems for primary care. Many times the most challenged communities have the least access to care. So we worked on sort of how do we ensure that that access is available. And we targeted our programming at the major risk factors, in this case for cardiovascular disease. We looked at nutrition, we looked at physical activity, we looked at helping people to stop smoking, and we looked at chronic disease self-management. I can tell you the best ways in the world to improve the care of your chronic condition, but I'm not going to be there every day, 24 hours a day, to help you with that. Really, I need to be working on how do I help you to manage these things for yourself. And so that's why we had such an emphasis on chronic disease self-management. But it was also about creating a community that would support all of this. So we focused in on increasing community awareness and education. The screening events were a good example. We looked at increasing access to healthy foods. We talk about food deserts as being a problem. Again, that's sort of people who have poor access to transportation, who have chronic conditions, often have the least access to healthy foods. And so how do we increase access in the community? And there were a variety of strategies, often very low cost and very effective, to bring healthy foods in, including helping people with understanding how to cook those healthy foods. And then we also looked at the issue of physical activity, and we realized that it was about increasing access, but it was also about creating safe physical activity spaces. And so as a community, we worked together on that. Then again, because our interest was in engaging at the community level, we wanted this to be something that everybody in the community was aware of, and it was really transformational. So we organized something that we called the Biggest Winner. So it was a contest that we ran for several months, from April to December in the year that we ran it. It was modeled after a TV program in the United States called The Biggest Loser. And that's a program that really focuses upon helping people to lose weight. But the people in our neighborhood said, everybody thinks we're losers. We don't want to be called losers. There's nothing to be gained by being the biggest loser. And so we decided, okay, then we'll be the biggest winner. So we targeted the three major means of health-related behavioral change: nutrition, physical activity, and healthcare monitoring and management. And what we wanted to do, and what we succeeded in doing, was getting people to commit for a period of 4 months, that each month they would do activities that within those three areas, and that they would get points awarded for the activities that they did, and that people would commit to 4 months of these activities and to gaining at least 30 points each month. And if they did that, they'd be able to qualify then for a grand prize drawing. But at the same time, anyone in any month that turned in a scorecard would also be eligible for monthly prize drawings. We targeted 3 communities, West Hill and the 2 neighboring communities of Arbor Hill and the South End. These are very challenged communities. These are often the communities that are an entry point for immigrants to upstate New York. These are also communities where there are groups that have lived for a long time, and they are also communities where there's often a lot of transition in housing. It is a very ethnically diverse community. 20% of the population is over age 65. Almost everyone is low income. And about 35% were below what we call the federal poverty line. And these are communities that are health disparity areas, that there is a disconnect between the level of need and the services that are being provided to people. There's also issues in these communities of crime. There are large numbers of children who've been designated as at risk, and a lot of shut-in older adults who just didn't leave their homes very much. What really worked in this community was, and for the Biggest Winner contest, was that we engaged with organizations to be partners in this campaign. They became the places where people could go to get information, to register, to participate in activities. We ended up with 238 people who committed to the 4 months and got their 30 points each month. But we probably had about 1,500 people who participated overall. in activities held at the portal sites. We were highly successful in engaging people who are most at risk. For example, among our contestants, the diabetes rate was 24%, which is about 3 times the rate in the rest of New York State. And about a third of our participants smoked, which is higher, again, than sort of the typical rate in New York State. So this was not about getting people who were ready to make change and who didn't have a lot of change to make to be healthy. We were really targeting people who really needed these programs. We used evidence-based programs such as the Chronic Disease Self-Management Program. We built a workforce in the community, largely of volunteers, largely of people just like the people who were participating in the classes. We developed I can't say we developed, a sense of community really developed. We started seeing teams being formed at the sites, for example, walking clubs, groups who would go together to shop at the supermarket, and just teams of people who would work together and support each other in participating in the activities. We looked to link our existing organizations within the community with new ones to the neighborhood, for example, a food co-op, an Asian arts group, all of which were really working to support each other and to support the people in the community. But I think the most important thing that the Healthy Hearts on the Hill Coalition achieved was that when this work all started, a lot of people said, well, nothing's going to happen. Look at all the problems that this community has. You're not going to make a difference. And what really changed over time, and what the biggest winner contest helped us to highlight, was that the coalition was delivering. There were things happening. There was excitement about the competition. When we had that final event where we awarded the grand prize, it was standing room only in the hall that we were using. And we were using the largest hall that we could find in the community because it was important to us that it be in the community, that people see that this was something that was happening here and that it could happen. Some of the other benefits included that there were lots of personal stories among the people who participated that reflected extraordinary gains that they made in improving their health. And again, this was not something on a TV program or on an advertisement in the newspaper. These were people who you knew, who over the 4 months you saw walking much more, you saw had clearly lost weight, who could talk about how their A1Cs had gone down. And the other thing that we hoped for, but were impressed by, was that we saw people stepping up and volunteering to help each other. It wasn't just a case of, I'm going to do the activities. I want to help some of my neighbors participate in the activities as well. But it was that expectation of community change that we think was sort of one of the most important things that we did achieve, and which sort of helped to then sustain the activities that we had started. So we learned a lot of things during the project. Community organizing, changing a community is a lot of hard work. There's a lot of meetings. There's a lot of people to be talked to. There's a lot of challenges that will present themselves, and sometimes it'll feel like 2 steps forward, 1 step back. But yet it's still very rewarding work. It's important that you build strong relationships within the community, between the different organizations. That's how sustainability happens. It's not about somebody new coming in and doing something really great. It's about a partnership. And it's about people having the time to work with the group of people that they serve around these issues as well. It's about identifying champions and advocates for your program. And it's thinking about sustainability in every decision that you make. You don't do for people, you do things with people. That's how you create a legacy. That's how things will be carried on after you leave. Joel Barker said that vision without action is merely a dream. Action without vision just passes the time. And vision with action can change the world. So I'll add to that you have to start with a dream. And I think that that's what this conference is about. It's about stating the dream, stating the vision. The next step is action. And so I hope that in sort of what I've presented, that you see how one community worked on action. And it's the combination of the dream or the vision with the action that can change the world. You start changing the world by changing one community at a time. And so I want to thank Father Thomas, and I want to thank the universities that have organized this conference, and I want to thank the organizing committee that invited me to present. And I hope in some small way I can help articulate the dreams and talk about how action with those dreams can change the world. Thank you.